Abdominal compartment syndrome. This is an extremely lethal problem in surgery and will get any surgeon to come running, all right? So if you don't know a lot about abdominal compartment syndrome, today is your day. We're gonna go through the diagnoses, the pathophysiology, how to treat it, and if you stick around to the end, I'm gonna teach you the steps that we can take to help prevent this extremely lethal problem. Let's go. Welcome back to Citizen Surgeon. My name is Dr. Eric Pearson. I'm a pediatric surgeon. I'm here to get you comfortable on the wards, in the ICU, in the operating room, and of course on your exams. Today, abdominal compartment syndrome. We're gonna go through this very, very lethal problem. Well, I'm gonna take you to a paper that I wrote as a resident with the help of the team up at Primary Children's Hospital in Salt Lake. And we looked at decompressive laparotomy in children with abdominal compartment syndrome. We found that there is a 58% mortality in kids who end up needing decompressive laparotomy. And the mortality rate in adults is also very high, and left untreated, whether you are a child or an adult, death is almost certain. So today we're gonna go through all of the details in abdominal compartment syndrome. So how do we define abdominal compartment syndrome? Well, there are two terms that we got to understand first. Now, number one is intra-abdominal pressure. Well, what is that? Well, the normal intra-abdominal pressure, that's the pressure at rest in the peritoneal cavity in a supine position, so laying flat. That pressure is 5 to 7 millimeters mercury. Okay, now in pregnancy or in morbid obesity, we can see that this number increases. 10 to 15 would be a normal intra-abdominal pressure in someone who's pregnant or somebody who's obese, okay? So what is abdominal perfusion pressure? Well, the abdominal perfusion pressure, much like cerebral perfusion pressure, is if we take the mean arterial pressure minus the intra-abdominal pressure, okay, the one we just talked about, that is the pressure in the vessels perfusing the intestine and the abdominal organs, okay? Now, if intra-abdominal pressure goes way up, we can see that the abdominal perfusion pressure goes down, and that's really important when we're talking about gut and solid organ perfusion, and we're gonna get to that a little bit later. So knowing those, we can start to think about, well, what are the scenarios in which we get an increase in intra-abdominal pressure? So we have hyperacute intra-abdominal hypertension, okay? That might be a cough or a sneeze. You know, you valsalva, you tighten up your muscles, and that increases the pressure of the abdominal cavity. Now that's only over a couple of seconds, okay? And then we get acute. Now that is over minutes to hours, okay? And we're gonna talk about the causes of that. Then we get subacute, that's over hours to days. And then of course, chronic intra-abdominal hypertension is over weeks, okay? Now, which of these are we worried about when we think about abdominal compartment syndrome? Well, we're worried about acute and subacute. And the reasons for that are right ahead. And so how do we define abdominal compartment syndrome? Well, abdominal compartment syndrome is intra-abdominal hypertension or increased intra-abdominal pressure that's associated with new organ dysfunction. And I'm going to take you through all of the organs that suffer in abdominal compartment syndrome and what happens in each of these organs. But any new organ dysfunction that is associated with intra-abdominal hypertension, we can define as abdominal compartment syndrome. Now, what I don't want you to do is I don't want you to get stuck on a number, okay? So we used to hear that anything above 25 millimeters mercury is abdominal compartment syndrome, but you can have abdominal compartment syndrome at pressures much lower than that. So if we're monitoring, and I'm going to teach you what we do to monitor, you don't want to say, oh, well, you know, it's not 25 yet, we don't need to do a laparotomy. You want to look for new organ dysfunction. If you find that, then you have to institute measures to start to treat this thing, okay? So don't get stuck on a number. Treat the patient as a patient, the whole thing, looking at all the organ systems, and if we have rising intra-abdominal pressure, new organ dysfunction, abdominal compartment syndrome, we got to initiate treatment. All right, so what are some risk factors for abdominal compartment syndrome? What are some causes? All right, we're going to get into classification, primary and secondary, in just a minute, but what are some causes of abdominal compartment syndrome? So trauma, if you have a severe blunt trauma, we have solid organ injury or mesenteric tear or small intestinal injury in the abdomen, we have the buildup of hemoperitoneum or blood, that can be a cause of abdominal compartment syndrome. We can have burns. We can have severe acute pancreatitis, a ruptured AAA or abdominal aortic aneurysm. Ascites, severe ascites can lead to abdominal compartment syndrome. Of course, liver transplantation, and then most importantly, what we're going to talk a lot about is aggressive fluid resuscitation, all right? So these are all some common causes of abdominal compartment syndrome. Now, like I just mentioned, there is a strong relationship between intra-abdominal hypertension and fluid resuscitation. Okay, so in burns, if we have greater than 250 milliliters per kilo in the first 24 hours, we have an increased risk of abdominal compartment syndrome. In severe acute pancreatitis, we can see that the risk of abdominal compartment syndrome is lower if we use controlled volume resuscitation instead of a very aggressive resuscitative strategy. When we look at trauma patients, patients who have aggressively been resuscitated with crystalloids instead of blood products have a higher risk of abdominal compartment syndrome. And we see the same pattern in our critically ill medical patients, perhaps with sepsis and septic shock. And so I mentioned this briefly, but now we understand the risk factors, we got our definitions. So how do we classify abdominal compartment syndrome? Well, we can split this into primary and secondary causes. All right, primary means that the cause itself is leading to increased intra-abdominal pressure, and that leads to new organ dysfunction in abdominal compartment syndrome. Things like a ruptured AAA or severe acute pancreatitis, or trauma with a significant amount of hemoperitoneum or blood in the peritoneal cavity. In secondary abdominal compartment syndrome is when you get abdominal compartment syndrome because you're treating something else. And that because has to do with fluid resuscitation, okay? So as we give a large volume of crystalloid fluid, we do see it when we give large volumes of blood products as well. But if we give a large volume of fluid, we're going to get capillary leak. We're going to get a lot of increase in our interstitial fluid. We're going to get bowel edema. Things are going to start swelling. You know, we like to say, if you're puffy on the outside, you're puffy on the inside, okay? So all of that swelling is going to increase the intra-abdominal pressure. And the three real diagnoses that come to mind are sepsis, septic shock, who is getting a lot of volume resuscitation, our burn patients, and then severe acute pancreatitis. So severe acute pancreatitis can be both a primary and a secondary cause of abdominal compartment syndrome. So what is the clinical presentation of someone with abdominal compartment syndrome? Well, this is not your patient that's walking around the wards saying good morning to everybody. This is a critically ill patient, often intubated in the ICU. They often have a distended abdomen. We're going to see that they have increased respiratory distress or respiratory failure. Perhaps when they're intubated, we're going up on our peak pressures, we're going up on our PEEP, we're going up on those ventilator settings because their requirements increasing. It's harder to expand those lungs against an elevated diaphragm, okay? We have oliguria, so decreased urine output, and hypotension, so decreased blood pressure. I'm going to give you some reasons why those things happen. And because the blood pressure is decreasing, we're going to see tachycardia as the body is trying to maintain that cardiac output. So remember, cardiac output has to do with your stroke volume and your heart rate. So if our stroke volume's dropping because our preload is down because the IVC is, or the inferior vena cava is smushed and blood's not getting back, then the heart rate is going to increase to preserve that cardiac output. And so why do these symptoms happen? So I'm going to take you to a little physics lesson. We're going to take you back to Pascal's law. Now, what did Pascal's law say? Well, Pascal's law said that in a closed container, if we increase the pressure, that pressure will be exerted on all the surfaces equally. okay? Now, what's this have to do with abdominal compartment syndrome? Well, that means that as the pressure increases, that same pressure is going to be applied to the intestine, to the vessels supplying the small bowel, to the bladder, importantly. Okay, we're going to talk about that in a minute. To the inferior vena cava, and of course, to the diaphragms, so that they are pushed up. And that's going to limit our ability to oxygenate and ventilate. Okay, so we can see in this little diagram, we have this square kind of modeling that abdominal cavity, okay? And so as pressure increases, perhaps from volume resuscitation, the abdominal wall does have some compliance, and so it's going to stretch, but it can only stretch so far. That fascia is tight, and once it reaches its limit, it's no longer going to stretch. And so what happens if we're continuing that capillary leak and that fluid creep, and we continue resuscitating? Our pressure is going to go up dramatically, and that's going to lead to new organ dysfunction. And so how do we make the diagnosis knowing Pascal's law? Well, the way we make the diagnosis is by looking at the bladder, and we can do bladder pressure monitoring. Remember, if that pressure is going up, it's going to apply to all forces equally. It's going to push down on that bladder. And if we can measure the pressure in the bladder, we'll get a good idea of what the pressure is in the intra-abdominal cavity. So there are a lot of commercial options available for bladder pressure monitors, but if you wanted to set something up, you could do it something like this. So we have the bladder, we have a Foley catheter in there, the balloon's inflated, and then we have a couple of three-way stopcocks here. We have a pressure transducer, we have a 60 cc syringe, we have that going up to a bag of saline that's going to be on a pressure bag, okay, and then we have output also to the urimeter, which is collecting the urine, okay? And so we can zero that pressure transducer, instill at least 25 cc's of water or saline into the bladder, and take a reading through that transducer. That's going to give us the bladder pressure, but that is going to be a window in mimic what the intra-abdominal pressure is. So let's say we have our bladder pressure monitoring set up complete, okay? So I know I told you don't get stuck on a number, but numbers can help you let you know what your severity is, okay? So we talked about intra-abdominal pressure normal being 5 to 7, maybe 10 to 15 in that pregnant patient or that patient with obesity. But if we have intra-abdominal hypertension and we're thinking of that big list of causes, we could grade it, okay? So we have grade 1 through grade 4, all of the numbers here. That will give you an idea just how severe the intra-abdominal hypertension is. Now, what are two questions we need to think about? Now, one is, when we're making the diagnosis, we got to know the history, the physical exam, what happened to this patient, okay? What is the data? Are they intubated? What are the peak pressures? What's the blood pressure? Are we on vasoactive medications to augment our blood pressure? What's the urine output been, okay? And we also have to know what is the tempo of disease, all right? So is this something that's been occurring very slowly over days, or is this something that's changed over the last minutes to hours? Okay, so the tempo of disease is also critically important, all right? So what is happening in the rest of the body? I talked about tachycardia, hypotension, respiratory distress. So why do those things happen? All right, so we can see here we got the heart, we have the lungs, we have the intestine, we have the kidneys, we got the liver, we got the brain. So all the organs are affected in abdominal compartment syndrome. In each organ system is going to give us clues to new organ dysfunction. Okay, so let's look at the heart first. So why do we get hypotension or decreased blood pressure and tachycardia? First, as the diaphragms are lifted, remember Pascal's law, increasing pressure all directions, okay? Diaphragms are lifted, we're going to get cardiac compression, all right? We're also going to get compression of the inferior vena cava, and that's going to decrease preload to the heart and decrease our stroke volume. So that's going to lead to hypotension and then The heart again is going to make up for it, increase the heart rate to maintain cardiac output. We're going to get that tachycardia. In addition, because we're compressing the heart, we're going to get decreased contractility. So now the architecture of the heart has changed and it's not as good at ejecting blood. So these are the consequences of increased intra-abdominal pressure on the cardiac system. So how about the lungs? Now remember, we're going to get increased airway pressure, not only because those diaphragms are elevated, but remember, we're also probably edematous in the lung tissue. We're going to get a significant VQ mismatch, all right? So increased airway pressures, elevated diaphragms compressing the lung. We also have decreased chest wall compliance, and there, like I said, the VQ mismatch, there's a significant shunt occurring. So this is what's happening in the pulmonary system. When we look at the kidneys, we're going to get renal vein compression, okay? So that increased pressure, if we look at renal vein pressure, this is low single digits. And so if the intra-abdominal pressure is 25, that's going to collapse that renal vein. That's going to decrease glomerular filtration, and that's going to lead to oliguria and even anuria. If we want to look at some numbers, oliguria or decreased urine output can start to happen as low as 15 millimeters mercury of intra-abdominal pressure. Once we get up to 25 or 30, we're going to see anuria. The urine output is just going to stop. Now, not only is there pressure on the renal vein, but the renal artery is also compressed by elevated intra-abdominal pressure. And just like we talked about the abdominal perfusion pressure, the renal perfusion pressure is also reduced. Now, how about the intestine? Well, the intestines are going to see reduced mesenteric blood flow. Now that's because the abdominal perfusion pressure is decreased, because that difference between the mean arterial pressure, perhaps that is being augmented by vasoactive medications, and we're already going to get some splanchnic vasoconstriction as the body's trying to shunt blood to the brain and other important organs, okay? So we're going to have reduced mesenteric blood flow. We're going to have venous outflow obstruction. So the superior mesenteric vein that drains blood from the intestine is going to be compressed. So we're going to have venous outflow obstruction. We're going to get intestinal ischemia. And then what happens when we get intestinal ischemia? We're going to get bacterial translocation into that peritoneal fluid, and that can start to hit that vicious cycle of sepsis and septic shock. Now, two more organs to think about. In the liver, we get compression of the liver, and that's going to reduce our ability to clear lactic acid. And so we can start to see our lactate increasing. Then finally, on the brain, when we have abdominal compartment syndrome or rising intra-abdominal pressure, we get decreased cerebral perfusion pressure. We also get increased intracranial pressure and obstructed cerebral venous outflow. So you can see that whether it's the heart, the lung, the kidney, the intestine, the liver, the brain, a lot is happening in abdominal compartment syndrome. And so when we see these organs start to fail and these signs being presented, we have to start initiating treatment. And hopefully we have started initiating treatment long before we see this organ failure. And so how do we treat abdominal compartment syndrome? Well, I like to think about it with three major headings. Okay, so remove, relax, and open. Okay, so what is remove? Well, if we can decrease any volume whatsoever in the abdominal cavity, then that's going to help. Okay, decreasing volume may allow us to take advantage of abdominal wall compliance, and it will decrease the pressure in the abdominal cavity. So we need to have a nasogastric tube in place, and we need to make sure that nasogastric tube has a sump on it and it's functioning. So make sure you know how to use a nasogastric tube, and make sure you know how to check it to make sure it's working correctly. If you want to see a video, maybe I could put a nasogastric tube in myself, teach you how to make sure it's functioning correctly. If you want to see that, leave a comment in the description below, all right? So what other things can we take out? Well, we gotta have a Foley catheter in place, draining urine. That's also gonna allow us a window to measure bladder pressure, okay? We could remove rectal. You can have a rectal drain or rectal irrigations if we need to remove rectal contents. And then, of course, if we have large volume ascites, we could have a peritoneal drain in place, removing that acidic fluid. So first is remove. Second is relax. So we may need to relax the abdominal wall musculature with sedation and paralysis to increase abdominal wall compliance, okay? So relax means sedation. It may also mean paralysis, then of course, pain control. Now, as we're instituting these treatments for relax and remove, if we still see that we now have impending organ failure and our tempo of disease is continuing, then we need to open. And what does open mean? That means a decompressive laparotomy. Now, in adults and in most kids, this would be a vertical midline incision that is a generous incision. You want to open up to completely decompress that abdomen, okay? Now, we'll often put in a temporary abdominal closure. I'm going to show you an example of that in just a second. And that is going to allow us to keep the abdomen open and control the fluid balance, okay? Now, just because we have an open abdomen doesn't mean that's it. I have seen before where we've opened the abdomen and we have a temporary abdominal closure in place and the patient gets abdominal compartment syndrome again, and we've had to open up that temporary abdominal closure. So just because we've opened the abdomen doesn't mean our job of monitoring and treating this patient and paying attention to organ failure is over. We have to constantly be monitoring until we start to see improvement. Now, what does that temporary abdominal closure look like? Well, this is the device that I like to use. It's called an Abthera device, and it kind of looks like an octopus, all right? So it is a sheet of plastic material, and inside, it's two sheets, sandwiched inside is this foam. And what that allows you to do is you cut that to size, and this lays in between the intestine and the anterior abdominal wall, as you can see in this diaphragm, and those foam tentacles kind of suck fluid up from those pericolic gutters and help reduce the likelihood of the fascia kind of separating, all right? So this helps us with fluid balance and keeps all the intestines in place, all right? So that is an Abthera device. If you don't have that, I've used sterile radio cassette covers before. Another one that I like to use, but I don't think balances fluid as well, is if you take a surgical blue towel, you could put that between two sheets of IO-band, and you could use that as a kind of sheeting between the intestine and the anterior abdominal wall, okay? And then we'll put a vac sponge in the wound, and we'll put that to some negative pressure. All right, so that's a temporary abdominal closure. Eventually, when we're done and we've treated the patient, we will take that out and then close the fascia. And then we can choose what to do with the skin, whether that is a delayed primary closure of the skin, or we leave the skin open and let that heal by secondary intention, okay? Now, if you want to check out the wound healing videos and the surgical site infection videos, I talk a lot about wound closure techniques. Now, how can we prevent abdominal compartment syndrome? Well, here I really want to refer to secondary abdominal compartment syndrome, and that has to do, how do we treat people with fluid? Okay, now fluid is a drug, and we have to think about the 4 Ds when it comes to any drug. So what fluid are we going to use? All right, how much are we going to use? When do we need to stop? So how long are we going to use it? And when we de-escalate, do we stop the fluid, or now do we have to actively remove the fluid? Perhaps with a diuretic like furosemide, or with dialysis, so CVVH, to remove fluid. As we talked about in the beginning, we know that large volume crystalloid resuscitation, whether it's a burn patient, a trauma patient, a patient with severe acute pancreatitis, is associated with an increased risk of abdominal compartment syndrome. If we are doing volume resuscitation with trauma, it's important that if we are a non-responder, that we quickly move from crystalloid to blood product transfusion, okay? So we could use 3:2 of red blood cells to FFP, and 5:1 of red blood cells to platelets to make sure that we are not giving too much crystalloid and increasing our risk of abdominal compartment syndrome. Other fluids that can be helpful may be hypertonic saline or even colloids, like using a 5% albumin in our resuscitation may decrease our volume and decrease our risk of abdominal compartment syndrome. How else can we prevent it? Well, we can have a very high index of suspicion. If you have a critically ill patient with one of those causes that I talked about earlier, then we have to have a high index of suspicion that this patient might develop abdominal compartment syndrome. And if you're in medicine, you want to get the surgeons involved early, okay? Second is, if we are doing a large volume resuscitation or we have a critically ill patient, start bladder pressure monitoring early, okay? And that's going to give us a good baseline and help us understand the tempo of disease. Okay, so today, abdominal compartment syndrome, I hope you enjoyed that. We covered a lot of material in a short amount of time. I'm going to put a link to a bunch of really helpful papers, so check that out in the description below. If you like this, give it a like, give it a share, subscribe to the channel. I love to engage with you guys, so if you have any questions, ask them below. I'll get right back to you. Check out CITIZENSURGEON.com. Check me out on Instagram. I put a lot of short videos on there. I'd love to see you on that platform as well. And then, of course, as always, study hard, stay safe. I'll see you next time.